Thanks for joining us. I'm your host, Raquel Faria. I am an internal medicine consultant at the Centro Hospitalar Universitário de Santo António in Porto. Today, I'm joined by Professors Ronald van Vollenhoven and David Eisenberg from the Lupus Academy Steering Committee. Between them, they will be providing expert insights from the 13th annual meeting of the Lupus Academy, which they co-shared in Amsterdam early this September. David, Ronald, welcome, and thank you so much for joining us today. As I was saying, you both co-chaired the meeting and you started preparing it at least 1 year ago. Can you please give us a hint of what did you discuss on what you brought was important, what you thought was important to bring to the meeting, and if there is anything that you wanted to bring and was not possible? Ronald, can you please start?
Well, thank you, Raquel. I think, first of all, it is tradition now for 13 years to have the Lupus Academy annual meeting rotating through different European venues. And it was a great pleasure when last year the steering committee decided to have it in Amsterdam, which is where I live and work. And so for this reason, I had the honor of co-chairing this meeting together with David. And we did start very early on to discuss how the program would be shaped, what we would like to see, how we would be continuing in the tradition for the 13th year, but also how we would maybe look at some novel aspects. I think for the audience is to understand that it's primarily an educational meeting. The goal is to provide state-of-the-art updates on all the aspects of systemic lupus erythematosus, to give the participants an overview of what is now the way we see this disease, what we see as the understanding of the mechanisms, how we feel that patients need to be approached, and how we can then also treat the patients more effectively. And because of this focus, there's obviously a natural inclination to also include research aspects, to have also a focus on what is going to happen in the future. So it's current, but also with a look towards what's coming. And what is, I think, also very important, to have increasingly the role of the patient in the whole program. So having the patients being part of the program design, but also to really focus on the needs of the patients and their views. And I think we tried to build on all those elements and create a very comprehensive program. And we wanted to also open it up a little bit towards the other diseases that can be part of the spectrum of lupus and where comorbidities play a big role. And then I think it was a particularly great pleasure to do this together with David, because not only because of all your knowledge, David, and your experience, but you introduced one key element into the program, which I will ask you to clarify, having to do with music.
David.
So yeah, I absolutely agree with what Ron said, and likewise, it's really a great pleasure to organise the programme with Ron. I think we wanted, in terms of structure, to keep what I would call the best of the old. It's always been a very interactional kind of process involving the workshops, which get repeated, so everybody gets a chance to go to 2 of them out of 4 or 5 or 6, however many we're running, but also to bring in some new thoughts. We hadn't done very much on the context of lupus and bones. We hadn't, I don't think, touched on lupus and HLH, which we thought was quite an interesting topic to go for. And then immunisation was another one which we thought hadn't really dealt with very much. So that will be a good one to do. We wanted to bring in some new blood. So we had a number of lecturers who had not been lecturing at the meeting before. I think we achieved what we set out to do, really getting that nice blend of the people who'd been around the block before, new ideas being incorporated, but also keeping the older structure.
Can you please,
David, the music.
Okay.
You have to tell us about that.
So, well, since you've mentioned it, by an amazing coincidence, I think about 6 of the speakers and chairs who were invited to the meeting also happened to be very, very good singers, and happened to be in a little band that I run. So it seemed churlish not to find a little entertainment during the reception, which I was very happy we were able to do, and we got some very nice things said about that afterwards. So it was a very nice mix of business and pleasure, you might say.
Yes, and of course, I was actually also thinking about how you did at an early stage decide that the program would have names, titles of the sessions with a musical reference. So if you now look at the program, you will see all these parts of the program with a name that may seem a little bit cryptic, but they are all allusions to either classical or modern music. And I think in the end that worked out really well. So I like that it was a kind of a small innovation with a little bit of humor.
I think we've set down a challenge to the people who are going to do next year's meeting.
Absolutely, set a high bar.
So just briefly, how do you both think that this meeting fits the evolution of the last 12 Lupus Academy? It has kind of the same format, but how do you see the evolution to this meeting? David, can you please?
Okay, so the meeting originally, just to add a little historical context, came about when GSK were about to launch Benlysta. And they came to Monica Kamashta and myself, and they said, look, we expect to make quite a bit of money from this drug, and we would like to give something back to the community. So they asked Monta and I if we could come up with an idea that would serve the lupus community. And we thought that some kind of educational meeting would be a very good thing. And we were very happy, of course, that GSK were prepared to pay for it. But in those days, they could do it on their own. But we obviously felt that it was very, very important that the meeting itself, its structure was completely independent, which it always was. Now, for obvious reasons, that's the funding sources have become much more diversified. But the nice thing is that the independence of the selecting committee for the speakers and chairs has remained. So I think that's very, very important. And so educationally, it's always had that kind of structure. We hit on the importance, I think, of the smaller workshops very early in the course of its development, and that's been continued. We wanted throughout the years to cover as many aspects of lupus and lupus linked to other conditions, as Ron was saying. That's been very important, and to sort of introduce new speakers as well as the older speakers. So I think I do see it as an evolution. It has very firm foundations, but it's certainly been, and the last meeting helped to sort of expand on those ideas.
Ron,
well, and I think we are obviously always trying to keep what's good and to improve further what can be done better. But I don't think any very major changes were needed. What we did actually do is, as just mentioned also by David, that we included a little bit more of other diseases that are very relevant for taking care of lupus patients. And I do think that the increasing focus on the patient, including also having a special workshop session for the patient perspectives, and having in the last session, which I think we will talk about, a very moving testimonial from a patient who is in part research, but also actually does have lupus himself and can tell us of his experiences. So that was also part of it. But these are not dramatic changes because we actually felt we had a pretty good educational program. Now, somebody who's been to the Lupus Academy meeting might say, okay, then do I need to come back next year because will you just do the same? And it's not exactly like that, because even in a 2-day program, there's so much you can cover, and there's also a lot of choices you have to make. In the end, there were lots of things we would have liked to include, but there just wasn't the time. So I think that whenever there is a new program, not even speaking about all the new developments, but also to make a selection of all the topics that are worthy of being addressed at the lupus conference, we still cannot always cover everything.
And for that, I can testify that I'm a frequent flyer of Lupus Academy. I think I only missed 2. So I do agree that if you go every year, it's always an educational that you come back with a lot of knowledge, and it's very, very good to hear people thinking. That's really the meeting where that happens. So I do think you need to come back next year. And going a little bit through the meeting itself, the meeting started with Enigma variations, not from Edward Elgar himself, but with different sides of the coin, lupus. And now people don't think I'm crazy because you already introduced that the music were coming as the theme. Jessica Mason's presentation highlighted the complexities of managing patients with HLH, including the overlap between HLH and SLE. David, for you, what were the key take messages from Jessica's presentation, and how should this be applied in clinical practice?
So I should say Jessica Manson is a colleague and has become one of the leaders of studies in HLH in the UK. And what she highlighted very importantly at the start of her talk was the fact that there are a number of clinical features which are common to both lupus and HLH, including fever, splenomegaly, cytopenias. And this is very important because on occasions, and very confusingly, these two diseases may appear at about the same time. So that was a very important point to make. She also highlighted the fact that HLH is often associated with an underlying condition, of which autoimmune diseases may be one, cancer of various sorts may be another, viral infections, etc. So you really have to push very, very hard to try to determine if there is an underlying condition. And then she concluded with a nice sort of review of the treatment, including a drug called etoposide, which I discovered yesterday was first used to treat this in 1980. So it's been around for quite a long time. And she highlighted the use of anakinra, steroids, even stem cell transplantation has been used. But it was a very nice overview of the field of HLH itself and its connections with lupus.
Thank you. Just after that, Sasha Bernstein.
Can I just add
Yes,
something?
yes, of course,
Raquel,
Ronald.
it was such an interesting talk, and I have to give full credit to Dr. Manson, who did such a great job in making a very complex topic seem relatively easy, although it was still complex, but she did a very good job in breaking it down. And what I took away from it was how many times did we actually miss this diagnosis? So thinking back of all the times when you had patients with lupus who presented with very severe symptoms, who were admitted, who had to go to the intensive care unit, who were treated with very high dosages of steroids and immunosuppressants, and unfortunately not always successfully. And how many times was it in fact HLH? Because we have not been so knowledgeable about this back in the past. And of course, in recent years, it's become more clear. And it's also sometimes referred to as macrophage activating syndrome. And the fine distinctions between those two are even beyond for me to speak about. But I think the point is that when a patient with lupus has a certain alarming presentation signs, then the diagnostic consideration of HLH should really be made. And I've taken that home as a very important practical lesson.
Thank you. Thank you. And just after Jessica's presentation, Sasha Bernetsky, presentation was on association of cancer and lupus. Ronald, what do you think were the main highlights of her presentation?
Yeah, so Sasha Bernetsky from Canada has been working on this for many, many years, and I've admired her work. There is clearly an association with malignancies as an increased risk. Interestingly, in the early stage of the disease, there is an increased relative risk of hematological malignancies. This is, of course, not a very big risk in absolute terms, but relatively it is increased. And later on, there are some other tumors that appear with increasing frequency in patients with lupus. Part of it may be explained by treatments, and we are still, after so many decades, seeing that cyclophosphamide used much more, of course, in the 1980s and 1990s, does have long-term consequences. Again, the absolute risk is not very, very big, but the relative increase is definitely there. And I think Dr. Bernetsky presented a very nice overview of this important topic.
David, do you want to comment anything additional?
Yeah, only to say that the one thing that surprised me slightly was that she didn't make more of the other interesting finding that the certain cancers are reduced in lupus, and she is part of the SLIC group. Also, there was the work of Zifa Day from Ghana when she was working here in London. Breast cancer, for example, is substantially reduced as a risk in lupus patients, which of course is very strange given that it's 90% disease which affects women. But no, the overview was excellent. And as Ron said, she's really a master of this art.
And after this presentation, Bridget Lenkens from the Netherlands and Rezit Yildirim from Turkey explore the continuum of lupus and infection and lupus and vaccination and immunization. David, clearly challenges remain for preventing and managing infection in lupus. So what did you capture as the main key points of their presentations?
So I was very keen to get Rezit, who had studied with me a couple of years ago in London. He's one of these sort of up-and-coming bright guys. And we had a discussion when he came as to what he was going to do. And we felt when we looked at the literature, there's quite a lot about the use of vaccination in the context of lupus being treated with conventional drugs, steroids, azathioprine, etc. But there was very little about the use of monoclonal antibodies and what you do in that context when it comes to vaccination. So he did a fantastic review, which got published in the Annals a year or so ago. And it was really an examination of the data that he'd found in the context of doing that study that he was presenting. So the two key main drugs really, of course, are rituximab and Benlysta. And essentially with rituximab, the key here is to vaccinate before starting the rituximab, if you possibly can do, and as long in advance as it's possible to do that. It's not always possible to do, but that's the general rule. The problem with Benlysta, which is a little bit surprising really, is there have been very few specific statements around, for example, vaccinations against pneumococcal infections, influenza, varicella, tetanus, etc. So we still need more data about that. In general terms, I think vaccination should be performed as according to the general population, but we definitely do need more data, and that point came across quite strongly, I thought.
Mm-hmm. Yeah, so I was pleased that it was possible to invite some speakers from the Netherlands and including from Amsterdam UMC. And one of them was indeed my colleague from infectious diseases with a very difficult Dutch name, Brechtje Lemkes. And so she actually presented about how you approach the patient where infection is a possibility. And of course, we all recognize that lupus being associated with immune disturbances can also predispose to infections, and treatments also add to that risk. So I think it brought home some important clinical messages to always be on the alert that a lupus flare may be a lupus flare, but it could be an underlying infection, and what the risks are that we need to always be on our guard for in the clinical setting.
And after these amazing Enigma variations, Sandra Navarra presented the data from the reality of the management of lupus in low middle income countries, and I felt humble with this presentation. Ronald, what do you think that Sandra brought us that is important to mention?
Well, I have such great respect for Sandra Navarra herself, but also for our colleagues who are working in essentially the same field, but under circumstances that are hard to imagine for us in Europe and North America. She, for example, explained that the Philippines, which is a nation consisting of thousands of inhabited islands, and it only has 100 or so rheumatologists. So how do you even start taking care of all those patients? And I just have to take my hat off for the colleagues who are doing this every day. And then she also touched on the important issue of having a fair distribution of resources. This has to do not just with medications, but also with the actual delivery of care. And she did point out some of the ways that they are trying to make it possible, and including also the use of novel technologies that do make it possible to be in contact, to have communication with colleagues about patients and communication with the patients even across long distances. So the hope is, of course, that things will get better in many different ways. Technology is one. Manpower in the field of rheumatology and rheumatic and musculoskeletal diseases is another, and the more equal distribution of wealth across the world is a third.
Yes, it was really amazing. And of course, David, you can jump in. Yes, of course.
So just to sort of, Ron's right. In fact, I think, Ron, what she said was that there are over 7,000 islands that constitute the Philippines. But the good news is only 2,000 are inhabited. So that was the good news. But what I thought was absolutely fascinating was the differential use of drugs in different parts of the world amongst the monoclonals. So she said that essentially in the Philippines, they can't really get hold of Benlysta. They certainly can't get hold of anifrolumab and voclosporin, but they can get hold of rituximab very easily. And this is so funny to me because in San Francisco, where Maria Dalera works, they can't get hold of rituximab, but they've got Benlysta and anifrolumab and voclosporin. In the UK, where of course we take the middle road, we can't get anifrolumab, but we can get Benlysta rituximab. So it's a very bizarre sort of situation, really. But it was a fantastic talk, and I echo what Ron says. One's colleagues in different parts of the world struggle with economic realities which we don't face certainly in the UK.
Yes, it was amazing. And after that, there was a debate. Crimea Rivaroxaban, not between Julie London and Justin Timberlake, but steered by Vittorio Pengo and Anna Cohen, who covered the arguments as to whether or not we should avoid using the new DOACs in antiphospholipid syndrome and in lupus with antiphospholipid syndrome. So, David, do you have thoughts on this?
We chose this because this is quite a hot topic, and although I think there is an evolution coming out in terms of the best way to approach this, it all kind of goes back to Vittorio Pengo's paper, and he's really one of the leaders in the field, about 2010, where he reported that in patients with ischemic strokes who are put onto warfarin, even those patients on warfarin have a recurrence rate of about 5% per year. Then Hannah Cohen, who is a colleague, came along 2015-16 and wrote up a trial, the RAPS trial, which showed that in patients with venous thromboembolism and a target INR of just 2 to 3, there was really reported the safe use of rivaroxaban versus standard dose rivaroxaban versus standard dose warfarin. And this was important because warfarin is not a very nice drug to be taking. You have to have regular blood tests. There's a whole load of drugs you can't take, a whole load of foods you can't eat. So clearly, it would be great if it was universally successful. But unfortunately, Pengo's subsequent trial, which had to be stopped, showed that patients with arterial problems had a much higher risk of strokes and complications if they were on rivaroxaban compared to warfarin. And that data was confirmed by Audie Ross. And then the problem got a little bit more complicated when there were sort of blanket bans issued by various European authorities that we shouldn't use rivaroxaban at all. And that actually doesn't make sense in the light of the data that's been published, Hannah's data and the data reviews from others, which indicate that for venous thromboembolism, where the standard INR is 2 to 3, actually, it's perfectly safe to take rivaroxaban for the patient's point of view. It's a much nicer way to go. So the data was sort of centered around there. I felt they were both more or less saying the same thing, actually. And in the end, I think everybody would agree that if you're triple positive for antiphospholipid antibodies, you probably ought not to be on rivaroxaban. You should be taking warfarin or BKR antagonists of some sort. And certainly for patients with arterial problems, that's true. But for patients with strictly venous clots, then I think rivaroxaban is actually safe to take.
Ronald, do you want to comment this?
Well, I can't add so much more than just to say that having a debate is very nice and interesting,
Yes.
and it has a certain amusement value. So what you see here is two highly knowledgeable people that know all the data, and they can argue two different sides, but they will each respect the other's point of view as well. And where in the end, the clinician ends up is having a little bit more uncertainty and having the fact that we could probably still use the DOACs in some patients with antiphospholipid antibodies. And I like having that balanced view. And I agree with David that it's really not good that so many organizations feel that they have to come out with a very strong one-sided recommendation, such as don't use any DOACs in patients with antiphospholipid antibodies. I do understand why they do that. They want to make it simple, but this simplification sometimes goes too far. I liked having both sides of the debate.
Yes, it was really good. And to finalize the scientific menu of the first day, there were 3 presentations on the latest advancement in lupus basic science, including genetics and their role in lupus by Leonid Padyakov, I'm struggling a little bit with the names, B and T cell interaction regulation by Claudia Mori, and the complex role of type 1 interference signaling in rheumatic diseases, mainly in lupus, by Thomas Donner. Ronald, these fascinating presentations provided deep insight in this complex pathogenesis of lupus, and they are really important so we can develop target therapies. What do you think were the main points for this session?
Well, I'll be brief because obviously we can't redo all this very, very complex science. But on the genetics, I think the bottom line is that there are genetic risks, and we still don't know exactly how that works. But on the mechanism of the inflammation, that is the interferon pathway and the cytokine-driven inflammation, I think we do understand a lot. And what I like is that has actually already led to some tangible improvements in treatment, such as the approval of the interferon type 1 receptor blocker anifrolumab, which comes straight out of the research line around the type 1 interferon system. And of course, now also in clinical development, some antagonists of cytokines, such as deucravacitinib, that target specific cytokines and has had promising results in early trials.
Thank you. And then the scientific part of the day finished, but you already heard that David presented a gig of music, but we also had a wonderful...
And Ron.
Yes, that was what I'm mentioning. Ronald presented a piano performance that was amazing also, and Anizor also read, not read, it just...
He memorized it, he recited it.
Memorized it and recited it. It was really, really... Thank you for preparing that. It was really amazing. And on the second day of the meetings, it started with Ronald, with Meet the Editor, and then interactive case studies workshops. Ronald, can you please just summarize the main points of each? What were the main educational points of these two rubrics?
Well, no, it was really a pleasure for me as an editor of the journal Lupus Science and Medicine to say a little bit about what is happening in the world of publishing. There have been, of course, tremendous changes with the advent of digital publishing, the online publication, and also the open access movement, which are really two separate things, but they tie into each other very nicely. So we talked about that, and then I also gave some hints if you want to get your paper published, what you should do and what you should not do. And I ended up with also some recommendations for those who review papers for journals, how to do a good review that is useful to the authors and to the journal editor, but that's also fun to do for yourself. So I hope that was helpful for those who attended this little workshop. And then indeed, the way the program is organized, for those who were not there, there were 5 or 6, now I'm not sure how we did it the first day, but there was 5 or 6 parallel workshops. So the delegates at the meeting could choose what they were going to be most interested in, with a diverse range of topics, such as the skin manifestations of lupus, cardiovascular. There was the patient perspective also as a topic. And so, of course, I cannot tell you what was said at all these, because I'm also just one person, but I think the evaluations of these workshops are always very positive because they're so interactive, because they're small scale, small group with 2 speakers who are also going into, question and answer and discussion with the group, and very positive reflections from the participants.
I don't know. One strange thing. I don't know if Ron's had this too. I was involved in the renal one, and as has happened every year I've done this, what fascinates me is that the speakers present the same clinical information and the same ideas in the morning as in the afternoon, but what the audience picks up on in the morning and the afternoon is completely different. It's so fascinating that certain aspects of managing renal lupus, as in this case, completely obsessed some members of the audience in the morning, didn't bother those in the afternoon. They were more interested in other things. And this difference makes it much more interesting for the speakers and the chairs. I think if you were doing exactly the same thing and discussing exactly the same points, it wouldn't be so interesting. But it was really great to see that difference. So I always enjoy that aspect of it.
Yes. Thank you for these comments. And on the Saturday's morning keynote, Murray Urowitz shed light on significant advancements in lupus treatment during the past 50 years. It was called Lupus in My Time as Tears Go By. David, can you comment on this wonderful presentation?
Yes, certainly. So Murray Urowitz has been a leader in the field of lupus clinical research for 55, 60 years. And it was his paper in 1976, which first distinguished 2 peaks of deaths in lupus. One early in the course of the disease, where it's the disease itself, its activity, which is often responsible. And then the later cause of death, often linked to ischemic heart disease. And he's really had a fascination with that for many, many years. And he showed us the data which has come out of his group, which the SLIC group has put together, a lot of this work has been also influenced by Sue Manz's work in 1998, I think it was, pointing out that if you're a woman and you're between 35 and 44, you are 50 times more likely to have a myocardial infarct, and that's a hell of a big number. So the question is why, and can we do anything about it? The why question is still not completely answered to my mind, but what Murray has shown is that much tighter control of the disease, better control of the disease, does seem now to be associated with a falling off in that very high figure. It's not back to what it should be, but it is certainly lower. And I think that was the key point that he was trying to make, that when you've got a nasty aggressive disease like lupus, you have to try to control the disease, not just for the sake of controlling disease, but also because it will minimize this rather very worrying, serious concern later on in terms of ischemic heart disease.
Ronald, do you want to add anything?
I don't really can add much to that, just enormous respect for someone who has spent his professional life working for lupus patients, who is taking care of lupus patients, and who has contributed immensely to our knowledge and understanding of this disease.
Yes. And just before lunch, the Thieves Market. Ronald, how do you think this rubric brings us knowledge?
Yeah, so this is always such a nice part where the participants of this educational meeting can also bring their own cases and come with some really unexpected and novel things, and then start a really good discussion with experts. So it's very interactive and very, very nice to do.
And then the afternoon started with a primetime session, Baby, You Can Drive My Car T Cells, and other novel therapies. It was very enthusiastic. David and Ronald, you both participated in this session. And what do you think were the most interesting parts of the session, and how might they change SLE clinical practice over the next decades? Ronald.
Shall I start? Well, I think everybody knows that in the world of autoimmune diseases in general, but certainly for lupus, there is now a tremendous interest in using CAR T cells or other innovative treatments that were really developed in the field of hematology, but that now seem to hold great promise also in autoimmunity. And what the common denominator is a very deep, profound B-cell depletion. B cells, of course, being the lymphocytes that eventually end up producing autoantibodies. So it stands to reason that eliminating them is good, but you could also wonder if that doesn't entail risks. And so the balance in part is what you get with all treatments, that you say, okay, we can treat maybe effectively, but is there a downside? And that still needs to be clarified further in trials. But what has generated the most excitement is not that you have maybe a new treatment as such, but that it seems to have the promise of achieving very long-lasting changes in the autoimmune process, a reset of the immune system, or a deep, profound immunological remission where there's no further need for treatment. Now, that is a promise or a hope, and currently it is based on a very small number of patients. So we have to be careful not to get ahead of ourselves and see if this can hold up in long-term studies for the future, but we do hope so, because it would really signal a dramatic change in how we approach a number of autoimmune diseases, including systemic lupus erythematosus.
David.
Yes, I agree. So CAR T cells are clearly the hot new kid on the block, and the results that have been published have looked truly remarkable. But it's also, I think, fairly clear this cannot be a way that's going to be universally applicable without some major changes, partly because of the cost, partly because in order to do this, you have to have top-class oncologists working with your rheumatologists, and that's not found universally. So there do have to be other approaches which are going to have to be used, and the talk that I was asked to give, actually I asked myself to give, I suppose, is to look at combinations of monoclonals, because this is an idea which has been very slow in coming to rheumatology. And I drew the contrast with oncology, where even as a medical student, it was absolutely common to see patients being treated with 3 or 4 different drugs at a time that the rheumatologists were giving 3 months of gold, then 3 months of D-penicillamine, then 3 months of sulfasalazine, or single drugs. So the frustrating part of this aspect is that we've had 3 trials now, 3 quite good trials, really, Benlysta and rituximab, and they've all come to rather different conclusions, which has been a little frustrating. And I said in my talk, maybe it's the sequence that's important, but we don't know. And Rich Fury then extended this because there's some very interesting drugs which are coming out now which have bi or even tri-specific targets. So drugs which combine an attack on the or can block CD19 or CD20 and can also block CD8 on T cells or CD8 and CD3 on T cells. And they'll be much easier to give because they'll be like any monoclonal. You come in for an infusion or subcutaneous injection, you have your infusion, you go home. It's a lot easier than spending 2 weeks in hospital while they take out your blood. They genetically modify your T cells to recognize CD19. That's a much harder ask. But certainly the Schett results with one patient now going 3.5 years with a seemingly normal immune system is sensational stuff.
Thank you, and I really need to congratulate you for bringing this table, because on the other meetings, people talk about B-cell depletion and CAR T cells and all of the middle things in between. It was amazing to hear. So thank you so much for doing that.
Rocco, I must tell you briefly, George is a very nice guy. He said to me, well, actually, he said, CAR T cell therapy is just very expensive B-cell depletion.
Yes. And the second primetime session was on organ-specific involvement and comorbid conditions in the heart and bones and eyes. Ronald, how would you summarize this enlightening session?
Yeah, so again, I was very pleased to have some of my colleagues from Amsterdam UMC as the speakers. Wouter Kokke, cardiologist, he presented about some manifestations in the heart, and especially, of course, myocarditis, how to distinguish from pericarditis, and also how to manage it. And then we also had a very, I think, insightful talk, no pun intended, on the eye, which was by Yuri de Hoog, and he presented about the many different manifestations in the eyes that can occur as a result of lupus, and how to deal with those in the clinic. And so this session actually was very practical and very useful, I think, for those who take care of patients.
David, do you want to comment?
Yes, I'd only add that Jude Big gave a nice overview about bones, focusing on osteoporosis and avascular necrosis. Again, as Ron says, very important practical points were made here because clearly steroids will, I think, continue to be used for lupus patients, so osteoporosis will continue to be a problem. How best to manage that in the lupus context is very important. So I think that was a very good practical session.
Thank you. And the final day started with the new kids on the block, both on lupus activity and damage tools. How will these tools, like SLE-DAS, EasyBilag, the new revised damage score, and the SLURPy, would improve our clinical practice? David?
Okay, so very briefly, the SLEDAI system, which Murray and Daphne Gladman introduced 40 years ago, it's relatively quick, it's relatively simple, but unfortunately, it doesn't distinguish patients who are getting better but not completely better from those who are the same or those who are worse. It completely forgets or forgot about hemolytic anemia, gastrointestinal disease, eye disease. So these are problems. So colleagues in Portugal have tried very hard to, in a sense, improve the global score system by incorporating those things and trying to give them some differential weighting. And it's called the SLE-DAS, and it's been used, it really has come out of Portugal in the last 3-4 years, and some great work has been done on that by Luis. The EasyBilag attempts to simplify the conversion of the recording of the individual items within the BILAG system into the ABCDE letter score, which currently requires, you can do it by hand, but often what we do in London is enter the data into a computer system, which gives us the readout. But with the color-coded system, which is EasyBilag is using, that really makes life a lot easier. And the damage index is still a work in progress. It was developed in 1996, published in 1996. It's the only damage index in lupus. It's never been revised. It needs to be revised. And Ian Bruce and the SLIT group are trying to do that. So this is definitely sort of steps, I think, in all directions, in the right directions.
And then
I think it's, yeah. No, I think it is important to know for the audience that the SLE-DAS and also the SLURPy developed by George Bertsias and his colleagues, they are available, they can be used. I think it is still a little bit unclear how the use will make a big difference in practice or in research, but it certainly deserves attention. The EasyBilag is actually a better way of using the BILAG, making it more feasible. So for those who are interested in the BILAG, and I think Ed Vittel did make a very strong case for the fact that we need the granularity of the BILAG with all the different manifestations of lupus that you can't interchange for one another. So it's just not right to say that arthritis equals skin rash plus pericarditis. That makes no clinical sense. And the BILAG keeping those things separate is a strength. And then the damage index will be revised, and that's a work in progress.
Thank you. And then the final session was on the long and winding road of renal failure. Ronald, what was the key take-home message from this presentation for you?
Well, there's two things, because one is that although we have made great strides in improving the treatment of lupus nephritis, and it is definitely getting better, so more patients are being spared the ordeal of having renal failure, there's also still an unmet need. So both things are true. And then I was very much touched by the presentation given by someone who is a lupus researcher, but also a lupus patient from the Netherlands, Jim Osmani. He gave a testimonial about what it was like when he was diagnosed with renal lupus. And that always brings home how important the work is that we're doing to try to give these patients better care, better treatment, and a better outlook for the future.
David, do you want to comment?
Yeah, I think this was a good session because we never really quite focused on renal lupus in quite this way before. Eliana Natsaki in particular was very interested in looking at the question of how do we persuade people to actually keep their appointments, take their medications on a regular basis, because that's the way to try to avoid going to renal failure the best way that we have. And then how do we manage renal failure once it's got started? I happened to see yesterday in the clinic a patient who had a renal transplant 20 years ago, and she would be the first person to admit that the reason that she went into renal failure is because, as she said to me, I didn't often take my medication. So those are very important practical points, and I think it was very good that we gave it a good airing for the first time in the Lupus Academy.
Do you have any final words on the meeting, David, Ronald?
Well, I don't know how Ron finds it. I find it very difficult to really enjoy meetings which I help to organise. It's only when the last talk is coming in that you think, yes, that went okay. But I have to say, this was an exception. This meeting I enjoyed throughout. So my particular thanks to Ron, who made it a very pleasurable experience putting the programme together, and to the speakers who I think really did a fantastic job. I found it very stimulating, very interesting, lots of time for discussions. And as you said, Raquel, what's great about this meeting is there's lots of time to see how people's thinking is developing, and certainly as you follow the meeting through the last few years, you can see how it has changed and how it has evolved, and I think in a good way.
Yeah, I think we had a really, really good meeting, but of course the delegates, the participants should be the ones to say that. But by now we've also seen some evaluations that were very positive, so we can be happy about that. I felt there was a very good atmosphere, and that is just a subjective impression. We had a very nice venue that also helped, and the weather was good, so that those are all things that you cannot always control. I do want to say that what is great about the Lupus Academy is also the team behind it, who are the organizers.
Yes.
That is Nicole Elzenbroek, Eugene Pozniak, and Julian Ball. And the three of them and on additional individuals supporting them have made it possible year after year to create what I think is an outstanding educational event.
Yes. And as a delegate also, I enjoyed a lot this meeting. Thank you for that. Ronald and David, thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of the Lupus Academy's latest education in lupus. Please download the Lupus Academy's 13th annual meeting report from our website. A link can be found in the show notes. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many as your colleagues as possible around the world.